Hello, everyone. Welcome to my YouTube channel, where we make pharmacology simple to understand. Now, ever wondered what really happens when patients are undergoing surgery, the kinds of medications we give them? One moment they are awake, the next moment they are not. Then by the time they realize they are awake again. Now follow me as we take a journey of looking at one class of these medications that we give the patients when they are supposed to undergo surgery. So today, we are going to look at general anesthetics. And as usual, this is Professor Kennedy Edem Kukia. Follow me as we take the journey. Now, what really is general anesthesia? It is a medical procedure that allows us to be able to induce a reversible state of unconsciousness in a patient. This happens because we depress the activity of the CNS. So the patient would be unconscious and the patient will be in a state that you cannot easily arouse them. So although it's as if the patient is asleep, this is different from sleep because, or this is more intense because you cannot easily arouse the patient. The medications we use to achieve this state of unconsciousness is what we call the general anesthetics, and the procedure is general anesthesia. Now, whenever we give these general anesthetic agents, there are a number of physiological states that would be produced in this patient. One is the loss of consciousness. Two is amnesia, because we don't want the patient to recollect whatever traumatic experience the surgery involved. We also don't want the patient to experience pain, so we create analgesia. Sometimes we have to do intubation, or we want to ensure that the person is not jerking whilst we are doing the surgery. So we do skeletal muscle relaxation. Then we also want to take control over autonomic activities like the heart rate, the blood pressure, the respiratory function, and all that. So we do what we call autonomic stabilization. Now, to achieve these physiological states, we cannot use one medication. Even if it was possible, you would need extremely high doses in order to do that. And that would predispose the patient to serious adverse effects. If you are not careful, the patient dies. So what we do is to do balanced anesthesia, where we give different drugs at different doses, normally lower doses, that ensures that we can achieve these physiological states without too much adverse effect or side effects. Also, when the drug is given, usually we seem not to realize that there are stages the patient goes through before we decide that the patient is ready for surgery. There are usually about 4 stages, though we don't require the 4th stage. But these drugs can induce 4 stages in the patient. Stage 1 is the stage where there is analgesia, and subsequently there would be amnesia. So at that point, the patient is still awake, but the patient would not feel pain, the patient would not remember. Stage 2 is a paradoxical stage because it is the stage where there is excitation, usually short-lived. Then stage 2 gives way to stage 3. Stage 3 is where we have what we call the surgical anesthetic stage. This is the stage where we can start the procedure. The patient is ready. But in stage 4, that is where the concentration of the drug is very high. We call it the medullary depression stage, where the high concentration of the drug, the general anesthetic, begins to depress the cardiovascular and respiratory centers in the medulla oblongata. And if you are not careful, the patient could go into coma. So these are stages. And as I said, you stop at stage 3 or you want to be at stage 3 whilst doing the surgery. We come to the types of general anesthetic agents. We classify them based on the way we administer them. So we have intravenous general anesthetics and we have inhalational or inhalation general anesthetics. We have propofol, we have ketamine, we have thiopental. Thiopental is part of a group we call the short-acting barbiturates. And then we have etomidate. These form part of the intravenous general anesthetics. Then inhalation general anesthetics, we have nitrous oxide, also known as laughing gas. We have halothane, we have sevoflurane, isoflurane, enflurane, desflurane, and sevoflurane. But for the purpose of today's discussion, our focus will be on just the intravenous general anesthetics, shall we? So the first intravenous general anesthetic would be propofol, a very popular general anesthetic agent. It is popular because of the fact that, one, we can use it for both induction of anesthesia and maintenance. So we use it to induce that loss of consciousness and to keep the patient in that state until we are done with the surgery. Two, it also has the tendency to produce a rapid and smooth recovery. So the patient doesn't normally have drug hangover when after we've used propofol for the surgery. Third one is the fact that it has a sedative effect, which allows us to use lower doses of sedative hypnotics whilst doing the surgery. Four, it has anti-emetic effect. This is crucial because most of the general anesthetics we use have the tendency of causing post-operative nausea and vomiting. And so since this propofol has an anti-emetic effect, we don't need to give a lot of the anti-emetic drugs to do the post-operative nausea and vomiting. Sometimes we may not even need these anti-emetics. Another advantage is the fact that the patient becomes ambulatory soon after the procedure. Together with the fact that there is smooth and rapid recovery, we are able to allow the patient to move about after this procedure. So if we do an outpatient department kind of procedure where we want the patient to be able to leave soon after that procedure, propofol would be a very good agent to use. The downsides of propofol would be, one, the pain at the site of injection. At high concentrations, it could cause cardiovascular and respiratory depression. Then there could also be the issue of propofol infusion syndrome, where we give the drug as an infusion. Now, this may not happen in every patient, but it could happen. And normally could be a medical emergency where there could be cardiomegaly, there could be leukemia, there could be metabolic acidosis and other ascites and other manifestations. We now look at short-acting barbiturates, where we take a look at thiopental, methylhexyl, thiamyl. Now, let me say that depending on the literature you are using, thiopental could be known as thiopentone, right? Now, these drugs are normally used for induction of anesthesia. Because of the fact that they reduce cardiac output, they cause a reduction in cardiac output. They could also cause a reduction in the blood flow to the brain. So we say that there is a reduction in cerebral blood flow. This reduction will cause the volume of blood reaching the brain to be lower, and so that would affect the intracranial pressure. So there's a reduction in intracranial pressure. This is useful in situations where the patient already has a raised intracranial pressure. The patient may have tumor or a brain trauma that has raised the pressure, and so we want to reduce that pressure, otherwise the brain tissues could be damaged. So this drug becomes useful there. The downside is that, one, it could cause cardiovascular and respiratory depression leading to coma in high concentrations. Two, the short-acting barbiturates are enzyme inducers. So they tend to induce an enzyme we call aminolevulinic acid synthase. which is responsible for producing certain heme metabolites, okay, before we produce heme, which is a part of a hemoglobin. Now, by inducing this aminolevulinic acid synthase, it means that we are going to have accumulation of the heme metabolites. The challenge is where a patient already has a susceptibility to porphyria, or what we'll call the accumulation of porphyrin rings. So if that patient has a condition where there is already accumulation of these porphyrin rings, there is the tendency of worsening the condition because you are inducing the enzyme that will make us produce more of these porphyrin rings. Another problem could be the fact that sometimes in trying to inject the drug into the vein, there is a mistake where you inject the drug into surrounding tissues or the arteries, and there could be pain, there could be local tissue necrosis, there could be ulceration or severe arterial spasm, which could lead to gangrene. To address this problem, we may decide to give a drug called procaine. Procaine is a local anesthetic, so it could suppress the pain. Two, it has a tendency of dilating the vessel, so the arterial spasm could be addressed and we do not have to get the gangrene. The next drug I want us to look at is etomidate. Now, etomidate could also be used in induction of anesthesia. It is quite useful in patients who are at risk of hypotension because unlike the previous two drugs, etomidate does not cause too much cardiovascular depression. And so patients at risk of hypotension may find this useful. The downside of this drug is the fact that it could inhibit steroid synthesis. So in critically ill patients, there could be the manifestation of oliguria, there could be electrolyte imbalance, and then there could be hypotension. Lastly, etomidate could cause pain at the site of injection. The next thing is to look at ketamine. Ketamine produces a kind of anesthesia we call dissociative anesthesia. Here, the patient dissociates from themselves, kind of, and sometimes they will be in a suggestive state. They could be answering questions, but they may not really know what they are actually telling you. So they don't have a recollection of whatever is happening. So there is amnesia. Then ketamine also has an analgesic effect, so it could suppress pain. Because of this analgesic effect, we consider it to be an excellent agent in procedures that involve children. It also usually keeps the bronchioles and the bronchi a bit patent, not too much bronchospasm. And so patients who are asthmatic may find this useful. Okay. Now, I'm not saying that they are used for asthma, but let's say an asthmatic patient is undergoing surgery. Because of the advantage ketamine brings on board, we can use it easily. Ketamine also causes cardiostimulatory effect. And so because of that cardiostimulatory effect, patients who may be at risk of cardiovascular depression may benefit from this a lot. The other issue is that cardiostimulatory effect means that there will be increased cardiac output that will lead to an increased cerebral blood flow. This would increase the intracranial pressure. So depending on the patient, this may not be too helpful. Then there could be also what we call sensory and perceptual illusions, where there are hallucinations. The patient could also have vivid dreams. This may not be too good sometimes for these patients. The experience may not be too good. But thankfully, we can use benzodiazepines such as diazepam to suppress the tendency for these emergence phenomenon. Now, to wrap up, let me say that in order for these drugs to produce their effect, they do so by depressing the CNS. And there are various mechanisms they use in doing this. One, some of these drugs could activate GABA A receptors. Some could antagonize nicotinic receptors. Some could open up potassium channels to allow efflux of potassium. Some could also work on glutamate receptors to block the action of glutamate. And so there are varied mechanisms they use to be able to induce that level of CNS depression leading to the anesthesia. This is all time would allow us for now. And this has been Professor Kennedy Edem Kukia. Don't forget to subscribe to our YouTube channel. Until we come your way again, stay safe and bye-bye for now.